So once again, my name is Lilian Moreko from the International Community of Women Living with HIV, and I'll be moderating this webinar. I would like to take this opportunity once again to welcome everybody who has joined and to thank our presenters who have kindly accepted to join us. I would like to start by saying that this is an important meeting for all of us, as you may be aware that the ECHO trial results were released on 13th June at the AIDS conference in Southern Africa. And probably most of you already know the detailed results, but maybe you could have also attended the several meetings that have happened as results have been shared and released. But today we are here again to reflect on the results, but also importantly to talk about what all this means for women, and particularly for women in Africa. I would also like to say that for majority of you and majority of us, this has been a long journey that started around 2012 after the release of the 2011 HEFRON study results that indicated that there seemed to have been, at that time, the feeling was from the observational studies that there was a relationship between HIV risk and use of hormonal contraceptives, and particularly DMPA. And it has been a journey that in 2015, when the ECHO trial started, we were all excited that at least we were going to get to the bottom of it, especially by the fact that we were all not sure of whether there was indeed a relationship or not. And as WHO also had communicated, issued guidance about the uncertainty and the follow-up messages that went out to women in terms of how important it was that, especially that they would have to be supported to weigh the risks and also look at different ways of how to protect themselves, especially if they were using hormonal contraceptives and as means of family planning, but also if they were from high-risk countries like our countries. So we are glad that we now have the results, but would like to get more into detail in terms of what does this mean? What does it mean for women? What does it mean for adolescents and young women? And what does it mean for women in Africa, especially where the studies were carried out and where we have the results now? So I'm glad to introduce to you our three presenters. We have three presenters, and this is how they are going to be lined up. We have Dr. Tim Mastro, who is a member of the ECHO Management Committee and the Chief Science Officer at FHI 360. Tim, you're most welcome.
Lillian, thank you very much. It's really a privilege for me to presenting along with Jared Baton for the ECHO Management Committee, and we'll be hearing from James Carey as well. So I'll quickly give the introduction to what's really an exciting event for all of us to be able to discuss. So
Tim, can you just hold it a little bit? I first do all the introduction so that when we start, then you just run through.
Okay, please.
Thank you. Thank you so much. No problem. And our second presenter will be Jared Baton, who is a member of the ECHO Management Committee, a long-term friend and colleague. He's a professor of global health at University of Washington and the director of Fred Hutch Center for AIDS Research. And lastly, but not least, we shall hear from Dr. James Carey, who is a coordinator at the Human Reproduction Team at World Health Organization, which is also a partner in the ECHO trial. So Tim, Jared, and James, you're all welcome, and I would like to hand over to you to take probably about 20 minutes in total, and when you're done, then we shall open it up for discussion and question and answer session. Welcome. So Tim, please go ahead.
Lillian, thank you very much, and apologies for the early start there. As I said, it's a real privilege for me to be presenting these results on behalf of a very large team that implemented the ECHO study. Can we have the next slide, please? So ECHO was led by a unique consortium. We had a 5-person management committee that included Helen Rees from WITS RHI, Nellie Mugo from KEMRI in Kenya, James Chieri from WHO, Jared Baton from the University of Washington, and myself representing FHI 360. Shown on this slide are the logos for the 12 study sites that included a leadership group of about 25 people, but really hundreds of staffers and workers that implemented all aspects of the ECHO study and enrolled the 7,829 women for whom we're very appreciative. Next slide. So this is a brief description of ECHO. ECHO was a multi-center, open-label, randomized clinical trial comparing new HIV infection or HIV incidence and contraceptive benefits in HIV-negative women living in areas of high incidence using one of 3 highly effective licensed contraceptive methods: DMPA-IM or Depo-Provera, a copper intrauterine device or IUD, and a levonorgestrel implant with the brand name Jadel. So the primary objective ECHO was to compare the rate of new infections or HIV incidence among these HIV-negative women who were randomized to the 3 methods, Depo-Provera, copper IUD, or the LNG implant. Secondary objectives were to compare the methods by the rates of pregnancy in the women, contraceptive method continuation, and serious adverse events and events that led to the discontinuation of their method. The trial began enrollment in December 2015, and study visits concluded in October of 2018. Next slide. This map shows the 12 study sites. We had 1 site in Kisumu, Kenya, 1 site in Lusaka, Zambia, 1 site in Eswatini, and there were 9 sites across South Africa. Next slide. HIV prevention was an important component of the ECHO study. At every visit, participants received a comprehensive package of HIV prevention services, including HIV risk reduction counseling, partner and participant HIV and sexually transmitted infection testing and management, condoms, and as it became part of the national standard of prevention during the course of the trial, pre-exposure prophylaxis. Next slide. So PrEP is an important part of the HIV prevention package. However, at the time that ECHO was started, PrEP was not part of national standards of preventive care, so PrEP became available relatively late into the course of the study. Women had access to PrEP through demonstration projects in some of the countries, and in 2018, the ECHO team provided PrEP as part of the package of preventive care in the South African sites. So overall, 622 women used PrEP with a pretty even distribution across the 3 arms here, DMPA, IM, copper IUD, and the levonorgestrel implant. But having said that, PrEP only overlapped about 195 women years in the trial, and there were roughly about 10,000 women years of the trial. So therefore, only about 2% of the total follow-up time was included PrEP in the women that were in the trial. So PrEP would not have had an opportunity to have very much of an effect on the trial outcomes. So I'm now going to turn it over to my colleague, Jared Baton, who's going to show us the results of the trial. And next slide, please.
Hello, good afternoon. Good morning, everyone. This will be a recap of the ECHO results. Please let me know if you can't hear me. Next slide, please. So, as mentioned, 7,829 women who were between the ages of 16 and 35 and desiring contraception and willing, after informed consent, to be randomized, were assigned in essentially equal numbers to DMPA-IM, copper IUD, or the LNG implant. And you can see the numbers across countries in in the bright box at the bottom. As expected, with 9 of 12 sites in South Africa, the vast majority of participants came from South Africa. Next slide, please. The group had characteristics that were, I think, similar to what many of us would have expected for a relatively young population living in these settings. The average age was 23 years, and almost 2/3 were under 25 years of age. Most were not married, and most had previously been pregnant at least once, both of those just over 80%. Half self-reported that they did not use a condom with their last sex act. However, importantly, only 7% reported more than one partner in the prior 3 months. And this is one of the emphasis points of ECHO, is that ECHO recruited clearly women who desired contraception, but otherwise women who recruited generally from the general community. We were not specifically recruiting for behavioral characteristics relating to HIV risk. The greatest HIV risk was sadly simply where people lived. We'll talk about HIV incidence in a moment, but STIs were also quite common in the population. 18% had chlamydia, 5% gonorrhea, and 30% had herpes at the time of enrollment. And then this last bullet, we tested blood samples from a randomly selected subset of participants from their enrollment visit to assess if individuals had used DMPA in particular in the 6 months prior to enrollment. The trial had eligibility requirement was no use of DMPA or IUD in the 6 months prior to enrollment. And about 13%, so a small minority, appeared to have blood levels consistent with use in the prior 6 months. Next slide, please. Follow-up in ECHO was done exceptionally well, and this is a tremendous testament to the really dozens, hundreds of people who worked on the ECHO study in all places, but particularly at each of the 12 localities, 12 study sites where the work was done. ECHO was challenged was charged with being an exceptionally well done study so that the answer could be as clear as it could be. And the information you're seeing here on this slide is the reason why we can have such confidence in the results, because the study was done so well. So follow-up was very, very good. 99% of women came back for at least one HIV test, and 93.6%, which is a very high number for 18 months of follow-up in such a young population, completed their scheduled final visit. 99.4%, incredibly, accepted their randomized method and enrollment, a real testament to tremendous pre-randomization counseling so that women were ready to be assigned to one of the 3 methods. And you can see of the only 44 women who declined, they break down fairly strongly for the copper IUD. That 36 of the 44 who declined the copper IUD, perhaps not surprisingly, as it was the least familiar contraceptive method in all of the settings. But then for follow-up, we had wanted participants to use their scheduled method for at least 90% of the follow-up time in the study, and we actually exceeded that. So participants used their assigned randomized method for 92% of the time they were in the study overall. Truly incredible. And those break out, as you can see over on the right side, fairly evenly across the 3 randomized groups. Next slide, please. So now we will talk about the primary outcome of the study, which is HIV acquisition. Of the 7,829 women enrolled in the study, 397 acquired HIV during the course of follow-up. That translates into an overall rate of new HIV infections of 3.81% per year. The trial was, just a reminder, the trial was designed anticipating that HIV incidence would be about 3.5% per year. And so the HIV incidence comes in just slightly higher than what was anticipated in the statistical design of the trial. Next slide, please. So there are three pieces of things to look at on this slide. I draw your attention first to the table at the top right. That breaks down those 397 HIV infections. 143 were among women assigned DMPAIM for an incidence of 4.19% per year. 138 were among those assigned the copper IUD for an incidence of 3.94% per year. And 116, at an incidence of 3.31% per year, were among women assigned the LNG implant. The two graphics at the bottom are the same graphic, just on different scales. The large graphic all the way to the left shows the cumulative incidence of HIV against a 100% scale. So the number, because the number is still 397 out of 7,800, the line stays very close to the bottom. The inset graphic blows that up, so the percentage is a little bit, so the lines are easier to see. The maximum percentage is 10% there. What you can see is that the three lines, blue for DMPAIM, red for copper IUD, and green for LNG implant, are relatively tightly grouped. There's crossing across the lines, so that no the method differences were not clearly emerging early in the study, and they stay tightly grouped really all the way through the trial. Next slide, please. Here we do the comparisons between them. These are the hazard ratios, the measure of increased or decreased HIV risk. The table at the top is the exact same table that was on the prior slide. The table at the bottom is actually the comparisons. So looking at the table at the bottom, first starting all the way to the left, for DMPAIM versus copper IUD, the hazard ratio, the measure of increased or decreased HIV risk, was 1.04, so almost exactly 1.0, with a confidence interval extending between 0.82 and 1.33, and a p-value of 0.72. In the middle, for DMPAIM versus the implant, the hazard ratio is 1.23, a confidence interval extending from 0.95 to 1.59, and a p-value of 0.097. And for the IUD, copper IUD versus the LNG implant, the hazard ratio of 1.18, with a confidence interval between 0.91 and 1.53, and a p-value of 0.19. Next slide, please. The ECHO measured many other important outcomes, two of which we present here: pregnancy, and then on the next slide, safety. ECHO is an incredibly valuable trial, and there will be many additional analyses that will explore these three different contraceptive methods and the general context in which they were delivered that will come out over the next many years. But at the time of this primary analysis of HIV, we thought it was important to include at least some important information about pregnancy and safety. So for pregnancy, the primary intention to treat analysis, so among all women, regardless of whether they were using their method that they had been assigned, is shown at the top. And then the bottom is a more limited analysis to when women were using continuously the method that they had been assigned in enrollment. The summary of both of these tables, the pregnancy rates, not surprisingly, were low. These are three licensed, available, well-known, well-characterized contraceptives, and of course, the contraceptives worked. Importantly, 71% of pregnancies that occurred happened among women who had previously discontinued their method. That's the difference between the top table and the bottom table. In the bottom table, when women were continuously using their method, the pregnancy incidence was very low, on the order of 1% per year, which is what would be expected for very good use of all three of these methods. Next slide. You can go to the next slide, that's fine. For safety, similarly, safety was very high. Serious adverse events, the top row in this table, was rare for all three groups, as were adverse events that resulted in method discontinuation, which is quite uncommon. However, adverse events resulting in method discontinuation were less common for women using DMPAIM, 4.18% on the bottom row of the table, compared to women using the copper IUD or the LNG implant, each about 8% and a little bit more. Next slide. So in summary, this trial, ECHO, measured HIV incidence among women assigned to one of 3 highly effective contraceptive methods. The conduct of the study was extraordinary. Acceptance of randomized method, contraceptive continuation, and retention were very high. HIV incidence was also high, about the same or slightly higher than anticipated when the trial was being planned, but still in excess of 3% per year, which is the WHO standard for WHO suggestion for populations at high risk that should benefit from PrEP, and far higher than HIV incidence should be in 2016, 2017, 2018, 2019. The summary of the primary outcome of the trial is this well-executed trial did not find a substantial difference in HIV risk among the methods evaluated, and all the methods were well tolerated and highly effective. Let's unpack that last bullet point on the next slide. We designed the trial to detect a 50% increase in HIV incidence for each of the methods compared to each of the others. None of the comparisons showed a 50% increase in HIV incidence. And none of them showed, and certainly none of them showed a more than 50% increase in HIV incidence. Under the design of the trial, an approximately 30% increase in HIV incidence would have been found to be statistically significant. None of the comparisons we observed was 30% or greater as well. Hazard ratios less than approximately 1.17 would have excluded a 50% increase in risk from the confidence interval. Next slide, please. So in conclusion, our results strongly emphasize need for more aggressive HIV and STI prevention and management efforts for African women, including PrEP and HIV prevention integrated with contraceptive services. These results underscore the importance of continued and indeed continued access as well as expanded contraceptive choices for these methods and other methods, complemented by high quality HIV and STI prevention services. Thank you for listening today. We are always eager to talk about ECHO and what how the trial was done and what the results may mean. It was wonderful to have you all on this call today. I'm going to pass back to Tim now. Thank you.
Thanks very much, Jared. Could we have the next slide, please? And as it was said earlier, we presented these results in the Durban, South Africa AIDS Conference on the 13th of June, and that was simultaneous with the publication of the full report of the ECHO study in the journal The Lancet on the same day. So that was widely disseminated, received a great deal of attention in the press, and we're pleased that the data, now that they're published, can be used by the World Health Organization to consider how the data should best be interpreted. Next slide, please. So the week after the results were presented in Durban, the ECHO investigators had a meeting in Johannesburg, actually just exactly last week. And it provided an opportunity to reflect on the ECHO study, talk about the experience, and frankly, celebrate the accomplishments of the entire ECHO team, express our appreciation to the more than 7,800 women that participated in the study. And it also provided us an opportunity to think about going forward in the future. So I have just 2 slides. I'll go through them, and perhaps these are items for us to talk about. So I have 1 slide on HIV prevention, implications for research and program, and 1 on contraception. So as Jared mentioned, there was a high rate of new HIV infection identified in ECHO, which is distressing to all of us who have been doing HIV prevention for much of our careers. So one of the questions is, how do we scale up more effective HIV prevention for African women, including young women seeking contraception? Pre-exposure prophylaxis is an effective tool. As said, it didn't have a large role in ECHO, and going forward, PrEP and perhaps new methods could contribute to HIV prevention. And also how to better integrate PrEP into family planning services. More broadly, how do we integrate family planning and HIV services to yield an HIV prevention impact? And that's really a challenge to all of us. As presented earlier, there are high rates of sexually transmitted infections in the women at enrollment, so we need to figure out how to improve STI detection and management, including better use of new assays that can detect asymptomatic STI infections, because we know that STIs can increase risk for HIV infection. And then importantly for women like the women in this study, how do we both assess HIV risk and communicate HIV risk so women are able to respond to that risk and take appropriate actions? Next slide. So the other key aspect of ECHO, of course, is contraception. And throughout Africa, there's a very substantial amount of unmet need of women seeking effective contraception. So the broader question, how do we meet that unmet need for African women and really women throughout the world? How do we reach women who are not accessing family planning services, including women before their first pregnancy and those in marginalized communities? And how do we expand the method mix beyond what's currently available? As we observed from most of our sites, Depo-Provera, DMPA was quite popular. In many sites, intrauterine devices and implants were not commonly available. So there are those methods that can be used to expand the mix. And looking at the three methods that were used in the domain of injectables, there are now 3 available injectables. There's the DMPA-IM that we used at ECHO, known as Depo-Provera. There's a new formulation of DMPA, which is used subcutaneously and can be used by self-injection, that was previously known as Cyanopress. And in South Africa, another injectable, NET-N, that's also available for use. There are essentially 2 implants available. There's the LNG implant that we used at ECHO, the Jadel, another formulation called Levoplant, and Implanon or Nexplanon, which is an etanogestrel, a different progestin hormone that's used for this type of implant. And there's questions of which implant is optimal to be used. There are a number of intrauterine devices. We used a copper IUD. There's also a levonorgestrel intrauterine system that's being rolled out in some areas, and there's other intrauterine devices to use. So implants and IUDs we commonly refer to as LARCs, or long-acting reversible contraception. And how do we assure that women that receive intrauterine devices or receive subdermal implants, how do we assure that they have quality removal services so they can have both the implants and the IUDs removed when they desire that? And we enrolled HIV negative women in ECHO, but there's important considerations for contraception for HIV infected women. There's potential for drug-drug interactions. Women on antiretroviral drugs potentially have interactions with hormonal contraception. Dolutegravir is a new ART that's being rolled out, and we need to learn more about the interactions between antiretroviral drugs and contraceptive hormones. And looking down field, there's potential for new methods, MPTs, multi-purpose technologies, products that can both prevent HIV infection as well as pregnancy. Investigators are working on biodegradable implants, 6-month injectables, and something called a microarray patch to deliver contraception. So these are all questions for us to think about going forward. Next slide, please. So finally, I'd like to thank the funders of the ECHO trial who had the confidence to invest in this globally important trial. The logos of the organizations are shown here. We're very appreciative of all the organizations that supported the study, and the contraceptive supplies were donated by the U.S. Agency for International Development and the Republic of South Africa. Next slide, please. And this is our last slide. This is the ECHO Consortium website where all of the materials related to ECHO, the published paper, questions and answers, and a variety of other documents are available on this site. So I'll finish our presentation here and turn it back to the moderator.
Thank you very much, Dr. Tim and Jared for that presentation. I would like now to call on Dr. James before we maybe get any clarifications or questions. So, James, if you're on the call, please go ahead.
Yes, thank you very much. I am here. And good morning, good afternoon, everyone. It's my pleasure to make this presentation on behalf of WHO and our department, the Department of Reproductive Health and Research. We participated as part of the ECHO Consortium, and colleagues in WHO are working on the next steps following the ECHO trial. I would really like to acknowledge the support of my colleagues, Dr. Petrus Stein and Marilyn Garfield, who worked with me on this presentation on what are some of the planned next steps. So next slide. So I won't go into this because this has been already highlighted from what are some of the implications from the ECHO trial. But I think the issue is that is very clear from this study is the issue of access to contraceptive methods is very important, and the importance to have the right of women to the latest and best information, and to have an access to a broad range of effective and acceptable methods, but also the need for us to step up our HIV prevention efforts, particularly in countries that have a high burden of HIV. So next slide. So how are we in WHO addressing this new evidence that has been presented in the ECHO from the ECHO study? One of the first steps is, of course, we have to now synthesize the evidence and look at it in totality, because the ECHO trial is additional to evidence that we had already on this issue of contraception and HIV infection risk. So WHO will be doing a synthesis of the evidence and getting what is the broader picture now in light of the ECHO trial results. This will be followed by a guideline development process that I will talk to you about shortly. And we are also doing a lot of technical support to countries to ensure that countries respond appropriately, and that countries actually do take steps in response to the ECHO trial results, and also in alignment with the WHO guidelines that will be issued. Next slide. So on the evidence synthesis, we are doing an update of the systematic review of the observational evidence. As has been mentioned, this has been an issue that has been long standing, and we are updating the review that was published in January 2016, and we are also updating a review on the use of the copper-bearing IUDs among women at high risk of HIV, because the copper IUD was one of the methods that was studied in the ECHO trial. We are also doing a systematic review on contraceptive values and preferences, and this will be published shortly, hopefully just on time or just after the guideline development group meeting. And we are also doing direct engagement with women at high risk of HIV on their values and preferences, and in this we are doing a qualitative study in Zimbabwe through the SESHA Sisters Project, and we are also conducting an online survey and in-depth interviews. The online survey is available in Russian, Spanish, and French. And after this webinar, for those who would like to participate on the online survey, I can be able to share the link with you. Next slide. So the guideline development process in WHO is really grounded in what we call the WHO Handbook for Guideline Development. And this is a process that is very critical, that we follow all the processes as laid out in the handbook, because this is what makes WHO guidelines so valuable and respectable. As already many of you know, the guideline development group members were announced and put on the WHO website on 27th of May. This was up for about 3 weeks for public comments, and we have received the comments and have acted on those comments and communicated with those who reached to us in terms of they wanted to know more about this group or they had specific requests. I would just like to highlight that the composition of the guideline development group really reflects the importance of this issue for WHO. More than 50% of the participants are women. Approximately 20% of them are representing the community of women that is really at the center of this issue and are affected by this issue of contraception and HIV acquisition. There's also a diversity of experts, including clinicians, human rights and equity experts, epidemiologists, basic science experts, and various experts in this field. And we also have to ensure that there's global representation with all regions of the world being represented. But about 2/3 of the participants are from low and middle income countries, with 40% coming from Africa. In terms of the guideline development process, we are going to use the GRADE approach. This is what is recommended by WHO. We will look at the quality of the evidence, benefits and harms, values and preferences, how important the problem is, and also look at issues of equity and human rights and feasibility. And this will guide us to what recommendations that we actually arrive to at the end. Other guidelines do look at costs, but traditionally in family planning, we do not look at the question of cost because we think that this is part of the rights of the sexual reproductive health and rights of the client. The guideline development group meeting is planned on 29th to 31st of July, and this is a date that has already been set some time ago, and we have confirmation from the guideline development group members on the availability on this date. And the question that they will really be addressing is that of contraceptive eligibility for women at high risk of HIV infection. And they will look at all hormonal methods and also look at the intrauterine device. Sometimes people wonder why we cannot immediately after the meeting on 31st July issue the guideline. And this is because there's a whole process that the recommendations have to go through after the guideline meeting, so that our target issue date is to issue the actual guidelines by the end of August. Once the draft revised guideline, if it is revised, is developed by the Secretariat, then it has to be reviewed by the guideline development group so that they see that that draft is in keeping with what they have recommended. And this is followed by a process of external review. And the external review group follows the same principles as the guideline development group in terms of membership. They have to be globally representative, have to be multidisciplinary, include the affected community, and this group, the members, are also approved by our guideline review committee, which approves all WHO approved guidelines. And I can say that already we have 2 community members who are represented in this external review group. After that review, then the guidelines are consolidated and finalized, and they are submitted to the guideline review committee for approval, which is followed by editing and layout, and then after that, the guideline are issued. So our anticipation is by end of August, we'll have the final guidelines issued. Next slide. So one of the technical support areas we are planning is we are actually planning a meeting that will be held in Lusaka on 10th and 11th of July. Initially, this meeting had been organized to be actually the official announcement of the ECHO result. But as you know, due to various things that happened, as you may be aware, the meeting has now been repurposed. It will still be held, but the meeting will be repurposed. And it's looking mostly at the issue of expansion of method mix and promoting choice. And also the issue of strengthening HIV prevention in family planning services. Specifically in this meeting, we'll have a brief presentation of the ECHO results, but some also presentation of some of the secondary analysis, particularly on PrEP use, on HIV incidence, and on STIs, and also on pregnancy incidence, that these secondary analyses are really very important for us to inform the two first issues that this meeting will be addressing. We will be planning to have these presentations as they are made to be accessible more broadly through WebEx, and we will be sharing web links so that those who will not be physically present in the meeting can be able to follow the presentation. We are also continuing to support country task teams in the various countries on the immediate responses, and also monitoring what is happening with the release of the ECHO trial results. And most of this has been focused on expansion of the method mix and the issue of policy and service integration. So next slide. Specifically, for the countries in which ECHO happened, we have a responsibility to give support to these countries beyond the ECHO trial. So we'll be actually conducting in-country workshops in these 4 countries after we issue the updated guidelines. And this will also include the family planning and HIV task teams that have been formed in those groups. And we will look at the issue of guidelines, the issue of integration, method mix, and also on FP HIV integration and following up on monitoring. So next slide. I would just like to highlight that in the WHO website, and on my computer I can't see it, but it's on this slide, and I'll be happy to share these slides after this webinar. We have various resources that are available. We have the WHO statement. We have responses to frequently asked questions, either about the guideline process, about the ECHO results, or about what the ECHO results mean, or about what WHO is doing in response to the results. We have also the current WHO recommendations. And from our statement, we are currently recommending that countries follow current WHO recommendations until updated recommendations are issued. We also have key messages for policymakers, for providers, and for women, for both high and low HIV prevalence countries. And finally, I would like just to highlight that for women living with HIV, their engagement with WHO, I think there's a long history, and I think our participation in this webinar is just testament to some of the collaborations we have had. But this has been a very important issue, and the WHO Director General has actually established a WHO advisory group of women living with HIV, and I've listed some of their mandates that are listed below to ensure their perspective are represented in WHO's work, and also to recommend priority areas for WHO. and to review and monitor our progress, and also to provide feedback on WHO normative guidance. And as I said, two of the members from this advisory group, one is participating in our guideline development group, and one will also be participating as a reviewer of the guidelines. And they also advise on values and preferences. So next slide. So this is my last slide. I just wanted to highlight that for us in WHO, we have been monitoring the media coverage on this issue. And I think so far what we have seen is that the media coverage on the ECHO results, on the WHO response, and on some of these next steps has remained very positive and balanced. And I think what is important for us is to continue working together and moving forward and collaborating well, so that we are not criticized for not responding appropriately. As expected, there's been a call for a focus on HIV, sexual reproductive health integration, and for broader method mix. And one of the things that we have captured is that the expectations are that the guidelines will be very clear, definitive, and that we'll have clear follow through to ensure that there's implementation and strong engagement of the communities. So thank you very much for your attention. And on the last slide, just to highlight the website for WHO, you can find those information I've highlighted there, and that is the department's Twitter handle. Thank you. And over back to you, Yvette.
Thank you very much, James. This is Lillian, actually.
Sorry, Lillian, I thought it was Yvette. Yeah.
We appreciate the presentation, and I just wanted to request that if we can stay on the call maybe for the next 15 minutes after the top of the hour, because we've taken long listening to presentations, but we'd also like to give opportunity to people who have questions. And I would like to call upon my colleague Yvette to take over from here as we get into the next session. Yvette, please. Yvette, are you there?
Yvette is on the line and she should be muted or unmuted. Sure.
We have a question from Lolo, and I think this should be going to the ECHO trial team. Tim and Jared, if you're able to respond to this question as we wait for Yvette. The question is, how many of the 397 women were part of those 600 plus who took PrEP? If there were any, and why was PrEP only introduced at a later stage? How was the 50% mark decided or agreed on, and why? Will these results be translated into a less scientific document that ordinary African community members can understand, and even in our respective languages?
Thanks, Lillian. This is Jared, and thank you, Lolo, for great questions. I can address. I can start addressing these, and others can chime in. PrEP was always part of the ECHO protocol. That the availability, that ECHO, in writing a protocol, said that PrEP would be part of the HIV prevention package as it became standard of prevention in the countries where they were hosting ECHO. And that was out of deep respect for wanting to do what countries were deciding as PrEP rolled into becoming standard of prevention. That happened at different points for the 4 different countries in ECHO, but all of that happened once ECHO was well underway. And thus, so PrEP became part of standard of prevention once ECHO was far into its follow-up. And that's why relatively little of the follow-up time had PrEP available. The other questions.
So of the 397.
97, yes, thanks, Tim. Of the 397 women, were there any who took PrEP? And of the 397 women, there were 2 women who at some point took PrEP, but one of them for sure had discontinued PrEP several months beforehand. And the other one, I think the information is not clearly enough known. The 50% number was decided in part by the ECHO team, but in part by a large amount of consultative work done independent of the ECHO team prior to the planning of the trial to determine an amount of increase in HIV risk that would motivate substantial policy change. And so that was, that determined the 50%. And yes, I think there are plans, probably for many quarters, to be able to translate both by language and by and technically the information about ECHO to make the findings and the knowledge gained here available as widely as possible. Thank you. Others, please chime in.
Yes, I would just say, and our colleagues at AVAC have been particularly helpful in that, the last part of that, of how do you take the language of scientific journals and modify that in a way that it's more broadly understandable. And that translation and adaptation is a really important part of this, and that is ongoing now and will continue.
Thank you very much. There's a follow-up question from Wanjiru. She's asking, you mentioned some effect from PrEP. Could you mention what these effects were on the 2%? And
yes,
members, if there's anybody who has a question, please post it in the chat room so that they can be attended to. Go on, Jared.
Thank you, Wanjiru. That is an excellent question. We are still in the process of analyzing fully what the impact of PrEP may have been, both individually for those taking as well as on HIV incidence more generally in the trial, and we hope to be able to talk about that actually probably in the next month. I think hopefully by IAS we'll be able to talk about that. So analysis is still ongoing. Obviously, the PrEP is already proven to be extraordinarily effective for HIV prevention when taken by women. So ECHO doesn't have to test that, but ECHO is a test of more real-world use of PrEP. Thank you.
Thank you very much. It seems we are having trouble hearing Yvette, but she sends her input, and this is what she says. What this study added was for us to zoom in on contraceptive availability and accessibility in the countries where the studies were conducted. Apart from the formation of the GCAG, the Global Community Advisory Group, was also the country task forces. This should be sustained and led by World Health Organization, and most importantly, the integration of HIV and sexual reproductive health and rights. James, I think maybe you can speak to that, and you mentioned in your presentation that you're continuously giving technical support to countries, but maybe if you could speak to this, but also share with us from what you're hearing and getting, how many countries are progressing with the task forces that were formed, but also I wanted you to respond to this. On your last slide, you mentioned that the question of DMPA has been settled. So I wanted to check in with you in terms of if there's no question anymore, if we don't have any question anymore, how do you see WHO taking on forward some of the areas that you highlighted as the next steps in terms, for example, guidelines development, working around method mix, and where do you think as WHO countries are going to get the energy to take on this piece of work? And I think also I have a question to the ECHO team. Do you see any need for further research, or everything has been settled? Over to you, James, and then later on
Yes, thank you. First, I think to respond to Yvette's comments, I really do agree with her that sustaining the task forces and the activities and these groups which bring both the HIV and the family planning worlds together is really very critical, and formation of these task teams should be an opportunity that we should not miss for activities in the country. How do we as WHO provide leadership to ensure that this happens? And if I'm to step back just to say that there's been a lot of efforts before today to try really to integrate HIV services and reproductive health services, and also a lot of efforts to expand method mix. But this has not been very successful. But I think the ECHO results present us with a unique opportunity where we are likely to have success. One, we are likely to have success because of the task forces, the task teams that have been formed in the country. And therefore, in the country, we already have structures that can move this agenda forward. I think the other opportunity, and we see it particularly like in this webinar, is just that we have engagement of a lot of advocates who were previously viewing themselves as HIV advocates, also becoming advocates for contraception and advocates for reproductive health. And this, I think, has enabled us to tap into a very rich world of advocates. So I think advocate-wise, we are like in a stronger position than we have been ever before. WHO is working with the countries. I think one is providing technical support and a follow-up post the Lusaka meeting, which will ensure that this does not end. Just to correct that, I did not say that the DMPA question is completely settled. I just said the angle that the media is taking is that they are now focusing. They are kind of, if you look at the headline examples I gave, they were kind of headline examples that this question is settled. That discussion, I think, is for the guideline development group to come up with what will be the recommendations, but also what is the way forward of in terms of the research. And I think it is be a question, as you have put, to the ECHO team, for the ECHO team to respond, because I think there will be a lot of scientific discussions on where we are with this evidence that is going to happen as we move forward. Thank you.
Thank you, James. Jared?
Yeah, briefly, I think I would have three brief responses. ECHO is clearly finished. and ECHO provided an answer, and that was all provided the answer to the questions it was asking, and that was always our intention, to provide the very best, most robust evidence we could. I think there are many questions that emerge out of ECHO, and many questions that ECHO could not answer. Part of that will be the guidelines development group, part of that will be additional science, and part of that will be additional advocacy. And I think the people on the ECHO team are eager to be a part of all of those discussions, because we really want as full information we can and the best health for everyone.
This is Tim. I'll just chime in. I think, you know, ECHO has provided a lot of extremely valuable data, and I think it will really stimulate the product development pipeline to come up with new and improved contraceptive options for women. We already have the DMPA subcutaneous formulation that's being scaled up. That is a lower dose and a subcutaneous way to administer DMPA. Women can self-administer this. So we think that will be another valuable option for women to use really in the now in some places and in the very near future. And there's various other development products in development that in the not too distant future will offer women even more choices that we hope will be very effective and very safe.
So thank you very much. I think we are losing James. James, thank you so much for being with us. And I don't know if there are any further questions, because we are already on top of the hour. But I think what is coming out is that this is an opportunity that ECHO has provided us, that one, we already have countries committed to task forces, and moving forward, we need to make sure that these task forces remain and take on the important role of integration, but that also ECHO provides us data to suggest that women in Africa, especially in sub-Saharan Africa, are willing and ready to take on all methods of contraception, and therefore we need to be working around getting new and improved contraceptives for women. So I think this is an opportunity, and James has given us a roadmap for WHO. I think all of us need to work around making sure that we follow the processes, but also that we take, and I think I'm hearing this from all our presenters, that we need to do more advocacy to make sure that the key things that are coming out from the ECHO study are not lost at this moment. And I think this is our moment now to take forward integration. So I think there's one question that is coming in. This goes to WHO, but I don't know if James is still around. I think, yeah.
James has left the meeting.
Yeah, so we've lost James. James has gone for another meeting, but I think we take note of the question, and we make sure that we get it integrated in the processes that James has elaborated, especially the Zambia meeting. I think these are some of the things that are going to be discussed and taken forward. So unless if there are people who have their hands up and they have something burning. So there are issues around what else ECHO should be giving us, and I heard the team say there's going to be more conversation around things that we are picking out of this at the Zambia meeting, and some of the issues that we think will be taken forward or can be extracted from the studies, if there are anything speaking to the structural drivers like gender-based violence, especially on the new infections, as Ntokozo is asking, and also as your Brenda asks around the youth-friendly and favorable services for young women, irrespective of the countries where they are coming from. So I think this is going to be work in progress, and if Yvette is able to say anything now, or if there's anybody else who has something to say, I would like to probably say that we adjourn our meeting and keep following us, keep following the conversation. For us as advocates, this is the beginning of a journey that we want to continue moving forward to the extent that we need to move integration from paper to reality. We need to push countries to make sure that integration is real, but we also need to move countries to make sure that method mix does not end on paper, but that women are able to get all the methods that they need and they are able to exercise their choice. So for us, that is the message, and we'll take it forward to the Zambia meeting, and we hope that the representatives, if they are still online, that are going to the guidelines review, should be able to take some of the things that we are hearing. But I would like to say thank you very much to everybody who joined the call. The call has been recorded and we shall share with everybody. Thank you to Levi for making this happen for us, to AVAC, to the advocates, the hormonal contraceptive and HIV working group. We thank you very much. And on that note, I would like to say bye until next time.
Thank you, Lillian.
Thank you, Lillian. Have a wonderful day.
Thank you.
Thank you all.
Thank you. Bye.